Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld. My apologies for getting started a few minutes late, but I know a lot of you guys are probably on your summer vacation, maybe just coming back from summer break. So we're going to gear up for this upcoming next semester. Maybe you're still in a summer semester by talking about electrolyte balance in the body, specific to potassium. So we're going to have a couple of questions sprinkled throughout today's lecture just to kind of test your knowledge, make sure everyone is staying up to keep. But we're going to have NCLEX style questions at the end of today's lecture that are going to officially test your knowledge on what we learned. So stay tuned for those. Thank you for saying hello, Nabi. I am happy to see you here. We do take into account the topics that you all want to see, so keep letting us know recommendations and suggestions for other topics you want us to cover. I think we have some GU coming up and some respiratory, so excited to get to those later this week. We are here to help you guys. We do have Nurse and Coley standing by, ready to answer any questions that you have or to look through your comments, and of course drop your answers to today's questions into the chat so we can see where everyone stands, what's everyone thinking. As always, this live will be on demand on Facebook, YouTube, Instagram, and TikTok, all of our social accounts. So if you have to duck out early or if you join late, you're always able to drop back in and use it as a future study reference. So speaking of that chat, let's get that chat going by letting us know where everyone is joining from. Who here is joining us from the US, who's an international viewer, wherever you are tuning in from. I see a couple of people already drop it in the chat. That's wonderful. We're so happy to have you all here. I see someone ask, I need to renew my subscription. How do I go about it? If you go to uworldnursing.com, you can find a link to our product, and it gives you different options for the renewal options. I think there's like a 2-week and a month option, and maybe even some longer ones than that. But again, uworldnursing.com, go to the Buy Now feature, and you can look at our renewal offers. All right, so with that being said, let's go ahead and get started. We're going to start out by looking back into the test plan. So every now and again on these lives, we jump back in and get in touch with the NCSBN, look at that test plan, and give us a good reminder of why do we choose the topics that we choose? Why are we studying this? We're studying it because it is important, and you are going to see it on your NCLEX. So the NCSBN, they are the makers of the NCLEX. They publish some really incredible resources for nursing students to review before taking the NCLEX so they can guide their test plan. One of these items is something called a test plan. It breaks down the test into client need categories and activity statements, and I want to read you guys what it says about electrolytes. So we have this slide pull up. You can read along with me, but under the physiological adaptation client category, which is essentially the category that covers all things disease processes, the activity statement reads, manage the care of the client with a fluid and electrolyte imbalance. Then more specifically, it tells us that we need to know how to identify signs and symptoms of that fluid or electrolyte imbalance, apply knowledge of pathophysiology when caring for the client with fluid and electrolyte imbalance, manage the care of this client with the imbalance, and evaluate the client's response to intervention. So we're going to use these points to guide our discussion today. A great way to jump back in and get started with our electrolyte topic here. We're going to be focusing on potassium, but what does potassium even do in the body? I like to think of potassium as like the MVP, the most valuable player of the body's electrolytes. So it's an important intracellular ion, meaning it mainly lives inside cells, and its role is to control the fluid volume inside of that cell. So I don't want to go too far into the weeds of things. We don't need to go too deep into the chemistry class, but I do want to make sure everyone understands the function of something called a sodium-potassium pump to really prime our lecture today. So we're going to pull up the sodium-potassium pump image. This pump is a critical protein. It's found on the cell membrane, and it's used to create the action potential of the cell, which pretty much is exactly what it says it is. It's potential. Essentially, it's slowly preparing the cell to be able to later do its job. So think of a pump like this. It's going to open inside of the cell and first grab 3 sodium ions, which is a positively charged ion. The pump is like, okay, great, we have a full crowd. I'm going to push you guys outside of the cell. And when I do that, I need 2 potassium in return. The pump will then pick up 2 potassium ions from the bloodstream, and the inverse, it will push that inside of the cell. So to note, potassium is also a positively charged ion. That's an important note for today's lecture. The thing that's really cool about the sodium-potassium pump is that it forces these electrolytes into a space of higher concentration. So essentially, to do this, it has to use energy. That energy is going to be called ATP, which stands for adenosine triphosphate, and it needs that energy to do what it is doing. That is called active transport because it requires energy. So sodium is moving from lower concentration in the cell to higher concentration outside the cell. Essentially, it is swimming upstream just like a salmon. And same thing with potassium. It's moving from lower concentration outside the cell to higher concentration inside the cell. Again, swimming upstream. This is what active transport is. The biggest takeaway from all of this to remember is that the exchange of sodium and potassium is important when it comes to influencing muscle function. We're going to talk a lot about muscles. So we need these ions to move in and out of cells to get our muscles to work correctly so we're able to do the things that we need to do. This is especially important when it comes to cardiac muscles, skeletal muscles, and smooth muscles, specifically those in our GI tract, is going to be a big part of today's lecture. So knowing that, now we've summed up the sodium-potassium pump, I hope you're hanging in there. We know that potassium should live in higher concentrations inside of the cell. So with that being said, let's learn what's the normal range of potassium. High serum potassium, hyperkalemia, and low serum potassium, hypokalemia, are defined by values that are outside of the normal range of potassium, which is 3.5 to 5 milliequivalents per liter. So hyperkalemia is going to be values greater than 5, and hypokalemia on the low side, values less than 3.5. So a big news alert. Do you guys know that you no longer need to memorize lab values for the next gen NCLEX? The new NCLEX was instituted in April of 2023, and the next gen NCLEX, you no longer have to memorize these lab values. So if you don't believe me, the NCLEX now doesn't include reference range, or it includes the reference ranges, so you don't need to memorize them on their own. You can check out the FAQ section of NCLEX.com. It was a great change they made when they instituted that next gen NCLEX. However, you may still need to memorize them for your nursing school curriculum, and unfortunately, I cannot get you out of that one. So let's start out with our lecture talking about hyperkalemia, that high serum potassium, and what happens in our body when we experience hyperkalemia. So let's think of the causes. Our causes of hyperkalemia in the big picture, when we have too much potassium, is because we either took too much in or we didn't get enough out. So essentially, potassium snuck out of the cell into our bloodstream, or we took in too much, or we didn't excrete enough. So this can look like a large intake of potassium, either through diet, or it can also happen if we're electrolyte replacing someone who is in hypokalemia and we accidentally overcorrected, putting them into hyperkalemia. This would be an example of taking too much in. But what's more likely is clients will get hyperkalemia from impaired kidney function because potassium is excreted through the kidneys through the urine. So things like acute or chronic kidney disease include a decreased GFR, which is a glomerular filtration rate. This can cause hyperkalemia because the filtering process of those kidneys aren't working effectively. We're not producing enough urine, and we're not getting off enough of that potassium. Quick little note, next week's lecture, next Tuesday at noon, will be chronic kidney disease. So if you're curious about this process, we're going to go through it in more depth, talk all about GFR next week. So medications can also cause hyperkalemia. Medications like a potassium-sparing diuretic that hangs on to potassium. An example of this is spironolactone, or medications that reduce the aldosterone secretion like ACE inhibitors, which we know is an antihypertensive. There are also a few conditions that cause hyperkalemia. So let's start with DKA, or diabetic ketoacidosis. In DKA, our body goes into a state of metabolic acidosis. So the pH scale is essentially a scale of hydrogen ion concentration in our blood. After all, pH stands for potential of hydrogen. So the more hydrogen ions in our blood, the more acidic we're going to run. We know that potassium and hydrogen have a direct relationship. So when one increases, the other will directly increase as well. When one decreases, the other will decrease. They work in tandem. So in DKA, we experience metabolic acidosis. So we have a higher concentration of those hydrogen ions in our blood because of the direct relationship. We can also expect to have a higher concentration of potassium ions in the blood as well. In the same vein as DKA, we can need to talk about insulin deficiency and hyperglycemia. How does this fit in to hyperkalemia? So DKA is extreme hyperglycemia. In DKA, we can see really, really high blood sugar levels. How do these all fit together? So you may have learned already that insulin moves glucose from the blood into the cells. That's why we use it to treat diabetes. It does the exact same thing to potassium. So if we have insulin deficiency or low levels of that circulating insulin, we're going to have high levels of potassium outside the cell because we don't have that insulin to go into the blood, grab the potassium, and move it into the cell. Conditions that cause cell destruction can also cause hyperkalemia. Think of our cells as balloons and the potassium as glitter or confetti being stored inside of that balloon. So things like rhabdomyolysis and tumor lysis syndrome, they burst those balloons, causing the explosion of potassium into the blood, which is what causes the hyperkalemia. So in rhabdo, this is essentially the breakdown of muscles and those bursting muscle cells. Since potassium, we know, is an intracellular ion, it's stored inside the cell. When it bursts, there's going to be potassium confetti in our blood, leading to increased serum potassium, putting us into hyperkalemia. Same principle with tumor lysis syndrome. So with these clients that have a really high cancer burden in their blood and they begin chemotherapy, when those cells start to bust open or lyse, a potassium confetti is going to be exploding in our bloodstream, and now we have hyperkalemia. Alrighty, so what does a client in hyperkalemia look like? Think about weak muscle problems. So think of hyperkalemia this way. We know potassium should live inside our cells. If we have too much potassium outside of our cells, we can assume that maybe our potassium tank inside the cell is running a little bit low. If that tank is low, we can't reach our full potential, which maybe is 100 miles per hour. We can only reach 40 miles per hour because that tank is low. We've also talked in the beginning about the exchange of sodium and potassium and how it's important in that sodium-potassium pump when it comes to influencing muscle cell function. So with all of that being said, what is an important muscle in the body that's affected by hyperkalemia? I'll ask that again. What's an important muscle in the body that is affected by hyperkalemia? And I'll give you a hint. We're going to pull up, or I've already pulled up, an ECG strip, which gives you a hint as to what part of the body we are talking about. I'll give you a few more seconds to answer. But you guys, per usual, are spot on. It's the heart. That's what I was looking for. So when we think about important muscles of the body, it doesn't get any more important than our heart. Tie this all together. If a client has hyperkalemia, we're going to be worried about changes in the electrical conduction of the heart, which will manifest in ECG changes. That's why we have an ECG strip here. High potassium can cause tall peak T waves, the absence of P waves. A great reminder for this is high K, meaning high potassium, equals high T, those tall peaked T waves. It can also lead to prolonged QRS intervals, or QRS complexes, and it can also lead to heart block. So when I think about weak muscle problems that we have in hyperkalemia, I think about poor conduction, poor communication within the muscle itself. And that was what makes me remember heart block. The signals just aren't quite making it where they need to go. So again, thinking about weak muscle problems, clients with hyperkalemia can also experience ascending paralysis, or paralysis that starts in our lower extremities and gradually works its way up. It's similar to the process of Guillain-Barré syndrome, if any of you are familiar with that. So knowing this, what are our potential complications? We're most worried about fatal dysrhythmias when it comes to hyperkalemia. So if hyperkalemia persists for too long, our client can progress from peak T waves to VFib and even to asystole. So we need to take this very seriously. Again, think about weak muscle problems, weak conduction, weak communication. All of that together really paints the picture of the potential for asystole, which is the total breakdown of the heart muscle and the heart's electrical conduction system. So we're going to move on to our hyperkalemia treatment table now. We talked about all these scary complications. Now, what can we as nurses do to treat these clients? Let's talk treatment. First things first, we always want to keep an eye on those electrolyte levels. We want to know where our baseline is, how high is their serum potassium in hyperkalemia. We know 5 is the top of our normal range. Is it 6? Is it 7? If it's 8 or 9, I'm starting to get very nervous. We always want to know our baseline and collect repeat levels per hospital protocol to make sure that we're trending in the right direction. Ideally, in hyperkalemia, we want to be decreasing our serum potassium. We also need to make sure these clients are on continuous cardiac monitoring. So if those ECG changes that we just talked about start to happen, we can give medications that stabilize cardiac cells. A big important one here is IV calcium gluconate. This is a priority to administer. I'll say that again, a priority to administer. This may come in handy in one of our end of the lecture questions, but it stabilizes that myocardial cell membrane. Important to note though, calcium gluconate does not decrease our serum potassium levels. It's solely given to stabilize those cardiac cells. But pretty simple, the rest of our treatments, after we stabilize those cardiac cells, we want to decrease potassium by either driving potassium back into the cell or increasing our excretion of potassium, and of course, limiting additional potassium intake. So speaking of driving potassium back into the cells, let's circle back to insulin. We know that we talked about earlier that insulin drives glucose and potassium into the cells. It like wrangles them up and lassos them into the cell, so to speak. So hyperkalemia protocol typically involves some sort of insulin administration. So we can give insulin. Which insulin can we give IV? There's only one kind of insulin that can go IV, and this is what we would give in the treatment of hyperkalemia. Does anyone know what type of insulin can go IV? I'll give you a few seconds. I'll wait for a few more answers, but yeah, you guys are spot on. Way to go. Regular insulin is the only insulin that we are going to be able to give IV. The rest of insulin is going to be subcutaneous injection, but that's a big safety thing for the NCLEX as well, just so you guys know. That sounds like a great NCLEX question. We also need to add in some IV dextrose because we don't want to make our client hypoglycemic on top of the hyperkalemia, because the insulin is going to take both the potassium and that glucose back into the cell. So we want to make sure we're not dipping these clients down and making them have low blood sugar. Other medications that help to shift potassium back into the cell include sodium bicarbonate or bicarb, as well as nebulized albuterol. The onset of these meds is about 30 minutes, so it takes a little bit longer to take effect. The second way to decrease serum potassium is to excrete it, is to get rid of it. And we can do this through the GU or the GI system. So we talked in the beginning about how potassium is excreted through the kidneys. So we can give a medication like a potassium wasting diuretic, like a furosemide, which is just Lasix as the brand name. We can give an oral potassium binder like a sodium polystyrene sulfonate, which is just Kxalate, which excrete potassium through the GI tract. But important to know, the GI system, the kidneys take a little bit longer to respond. So this is not going to be quite as speedy. Alrighty, if our kidneys are impaired, dialysis may be needed. So essentially, we may need to use a machine to take over the function of the kidneys and filter our blood back to normal levels. Because if the kidneys are impaired, like in AKI or CKD, they're unable to do this on their own, and we may have to resort to dialysis to do it mechanically for us. The last and easiest section is nutrition. If we have high potassium, we don't want to take in any more potassium orally. We want to avoid the high potassium foods like bananas, cantaloupe, avocado, spinach, oranges, and orange juice. We're going to have more on diet when we get to the hypokalemia section, which, speaking of hypokalemia, let's switch gears into that now. So switching gears, hypokalemia is a little bit easier, I think, than hyperkalemia, especially when you started with hyper, and now we're going to the easier part of hypo. So quick reminder, low serum potassium is what hypokalemia is, and that means we have potassium less than 3.5 milliequivalents per liter. So what are our causes of hypokalemia? Big picture, it's the inverse of hyperkalemia. Either we have too much potassium going out of the body or too much potassium that's going into the cell out of the blood. So let's visualize a client in the hospital room, and the starting point is going to be the stomach or the abdomen. Think about anything that's going to go up, like vomiting or NG tube suction, or anything going down, like diarrhea or increased urination. These are going to cause hypokalemia. This can be from medications like a potassium wasting diuretic, like that furosemide that got rid of too much potassium. Again, we can overcorrect from hyperkalemia and end up in hypokalemia. Or conditions that cause increased urination, like polyuria from diabetes or hyperaldosteronism. Let's also think about conditions that shift potassium into the cell out of the blood. So think back to our treatment for hyperkalemia with insulin. Too much insulin can cause hypokalemia and hypoglycemia. So double whammy there. We know that potassium and glucose are closely related. So for hyperkalemia, we talked about metabolic acidosis. The opposite is true for hypokalemia. We're more worried about alkalosis. Since hydrogen and potassium are directly related, where we have alkalosis, that means we have a low hydrogen ion concentration, and because they're directly related, we know potassium will be low as well. Now let's move on to our clinical features of hypokalemia. What are we going to see in these clients in a clinical picture of hypokalemia? So we can visualize too much potassium in our cells and not enough in our blood. So when our cells have too much potassium, they're going to be jittery. Think about how you feel if you've ever had too much caffeine, kind of on edge and jittery. It's the opposite. In hypokalemia, we're jittery, and in hyperkalemia, we were weak muscle. Here we're jittery, reactive muscle. Our heart is a muscle. We already declared that earlier. So we know that potassium really affects muscle conduction. And when we're thinking about the jitteriness that comes along with hypokalemia, it's going to make sense when we look at our ECG findings. So we can have PACs, premature atrial contractions, and PVCs, premature ventricular contractions. Essentially, our atria and our ventricles are too excited, they're too jittery, and they're firing too fast. Clients can experience dysrhythmias like VTach and VFib, which we know is dangerous. So in VTach, our ventricle is glitchy, it's going way, way too fast. We can also see muscle cramps from hypokalemia. So again, if hyperkalemia, what's the weak muscle? Hypokalemia is that jittery, twitchy, overactive muscle. Another big place we see this affect the body is in the smooth muscles of the GI tract. This can also be affected. So clients can have nausea and vomiting because of hypokalemia. We can see decreased bowel sounds and even constipation here. Alrighty, so with this being said, how do we treat hypokalemia? What do we do as nurses to help out this clinical scenario? So as always, first things first, monitor those electrolyte levels closely. We want to make sure we get a baseline and we collect repeat levels per hospital protocol so we can see, are we trending in the right direction? Are we getting better? Are we getting worse? We need to make sure these clients are also on that continuous cardiac monitoring that we talked about earlier, because we already know that potassium affects the heart. And we want to stop potassium from exiting the body. So we need to avoid those potassium wasting diuretics like furosemide. Maybe we need to switch it for a potassium sparing diuretic like a spironolactone. We also want to stop any GI losses of potassium. Maybe that's from diarrhea, maybe that's from vomiting. So we can give an antiemetic like an ondansetron or a Phenergan, or we can give an antidiarrheal like a loperamide or a Lamodal. Most commonly, what you want to do is correct the imbalance by actually giving the electrolyte itself. Pretty easy concept to understand. But we do know that potassium is a high alert medication. So a few things we need to know about medication safety. First and foremost, I'll say this twice, we never push IV potassium. Again, we never want to give potassium IV push. If you guys know, a lethal injection for someone on death row is a potassium injection. We never want to IV push potassium. This can be fatal to our heart muscle. Our cells can't navigate this quick influx of potassium. It can cause fast and fatal death very quickly. So again, we're never giving potassium IV push. We can give it orally, or we can give it via an IV piggyback at a slower rate. So if we're giving IV piggyback, we should never give it at a rate greater than 10 milliequivalents per hour. In reality, potassium, and if you've had a clinical, especially in someone who's maybe older with really fragile veins, potassium is a vesicant. It really irritates that site. Sometimes even 10 milliequivalents per hour. It's going to be too quickly. We'll need to kind of drop it down. We have to make sure we measure that potassium and the infusion for edema, for erythema, any signs of really infiltration there. Again, even if it's going in well, it's still going to be kind of painful. We always say that potassium is spicy, so we will have to closely monitor that IV site, especially in an older client. Lastly, as promised, our diet section. So we have to enact a potassium-rich diet for a client that's low in potassium. That makes a lot of sense, right? So the foods that we were avoiding in hyperkalemia, those high potassium foods, now we're looking to eat them in bulk. So think fast when we think high potassium diet. FAST stands for fish, avocado, spinach and strawberries, and the T is for tomato, trying to take lots of potassium in orally to help raise our potassium levels. So great job, you guys. That sums up our lecture. Now we have two NCLEX style questions to test your knowledge today. So let's pull up our first question of the day. The nurse is caring for a client with chronic kidney disease, or CKD. The nurse notes tall peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Should they administer the IV calcium gluconate to the client? Should they teach the client to limit dietary intake of potassium? Should they request a prescription for oral sodium polystyrene sulfonate for the client, or prepare the client for placement of a temporary catheter for hemodialysis? Drop those answers in the chat. I see someone said banana is also a great source of potassium. You are spot on. So true. I forgot that one. Alrighty. I see someone took their NCLEX yesterday. I hope you did well. I'm sure you absolutely crushed it. Alrighty, and to note here, this is a priority question. So it's not necessarily saying that all of these options are wrong. It's just saying that one is going to take precedence over the others. One is the most important to do quickly, to do first before we get to the other ones. Alrighty, lots of great answers coming in. And again, this talks about CKD. Next Tuesday, same time, same place, same day, we will be doing our chronic kidney disease lecture. So make sure you tune in for that next Tuesday at 12 p.m. Central Standard Time. Alrighty, great answers. It looks like the majority of you guys got what we were looking at, and that's option number one, that IV calcium gluconate is going to be our priority. So the question states there are ECG changes with hyperkalemia, i.e. those tall peak T waves is what gave this away. It's a priority for the nurse to administer IV calcium gluconate to a client who's hyperkalemic to reduce myocardial irritability, protect the myocardium from those potassium-induced dysrhythmias, and stabilize the cardiac cells. Remember our ABCs, airway, breathing, circulation. This affects the C of that ABC, so it's going to be our priority. We need to do this first. But important to note that calcium gluconate does not decrease our serum potassium. It solely stabilizes the cardiac cells. Option 2, 3, and 4, these are not our priority. So why is this? Teaching the client to limit dietary intake of potassium is important, but it's not going to be our priority because it doesn't address the ABCs here. Our C is our priority. This is something that we would do, but it's not going to trump, making sure our heart is taken care of. Option 3 and 4, similar thing here, requesting a prescription for that sodium polystyrene sulfonate, which is a K-exolate for the client. This causes excretion of the potassium through the GI tract. It can be administered by the mouth or by enema, but we always want to make sure we're giving the IV calcium gluconate first to stabilize those cells. This will help to decrease our serum potassium, this K-exolate. However, the GI tract works much slower, so it's going to take a little bit of time time to work. And lastly, prepare for that temporary catheter for hemodialysis. Impaired kidney function will often cause hyperkalemia due to that decreased GFR and the decreased renal excretion of potassium. The hemodialysis catheter placement provides temporary vascular access for that acute hemodialysis. This may be performed, it may be indicated depending on if the provider orders it, but it's not going to take precedence over stabilizing the cardiac cells by giving that IV calcium gluconate. So again, option 1 was our top, and someone got this too. IV is going to be our quickest route of administration. It's going to take effect quickest. Another reason that it is our priority. Way to go. You guys are absolutely killing this today. All right, question number 2, our final question before we wrap up for the day. The nurse is collecting data from a client with heart failure who is receiving furosemide. Which of the following findings would indicate the client is experiencing an adverse effect of the furosemide? So option 1 is 2 plus pitting edema in bilateral lower extremities. 2 is muscle cramps during ambulation. 3, fine crackles in the lung bases. And 4, increased urinary frequency. Drop those answers in the chat. Let us know what you all are thinking. Also, I'll give you a cue in to our schedule for the week. We will be doing mental health questions tomorrow on Wednesday at 11 a.m. and 7 p.m. Central. Thursday, we're going to switch to GU questions, and we are super excited about that. If anyone has questions about our schedule, uworldnursing.com is a great home base. It gives you our full calendar, times, channels, and topics that we're going to go live on, so you'll never miss a live. If you want to go ahead and tune into that so you can see and bookmark which lives you want to make sure you don't miss, uworldnursing.com again is a great home base. All right, I see lots of answers coming in, and it looks like we're kind of split between 2 and 4. And no worries, this was a tricky question. Our correct option was actually option number 2. So this client has heart failure. Common side effect of heart failure is going to be volume overload. They're receiving that furosemide, which is a non-potassium sparing diuretic. It does not hang on to potassium. It gets rid of it just like everything else in the urine. So in this case, we're looking for an adverse effect of the furosemide. So not an expected finding, but something that means that we had an adverse effect of the furosemide. So our correct option is option 2, those muscle cramps during ambulation. So furosemide, again, does not spare potassium, meaning it may take too much potassium off of the body, putting us into hypokalemia. And we talked about hypokalemia can cause muscle cramps. Again, we have those jittery muscles, twitchy muscles, which can cause cramps from hypokalemia. So this is the only option that identifies an adverse effect of the furosemide. 1, 3, and 4 were incorrect. So 2 plus pitting edema in the bilateral lower extremities. This is a sign of volume overload from that chronic heart failure. This is what we're trying to treat with the furosemide. It's not an adverse effect of the furosemide. Again, same thing with option 3, fine crackles in the basis, another sign of volume overload, which we see in chronic heart failure. The potential to progress to pulmonary edema. It's again what we're trying to treat with the furosemide to get that fluid off. It's not an adverse effect of the furosemide. And lastly, increased urinary frequency. A couple of you chose this one. When we give any diuretic, we expect urinary frequency to increase. That's the purpose of the medication. We want them to diurese to get some extra fluid off. This is an expected finding of the furosemide, not an adverse effect. So again, option 2 was correct. Way to go, you guys. So let's go ahead and jump to our QBlank slide really quickly. Here's how you can filter, one of the ways you can filter in our QBank to get questions that test you on exactly what we talked about today, more electrolyte imbalance questions. So for anyone already using UWorld, here's how you filter to get those. For anyone that does not have UWorld, here is a little quick glimpse into our QBank and just one of the many ways you can filter questions to get exactly what you want. In closing, thank you all so much for joining. This was a pretty dense lecture, but you all did so well. A reminder that all of these lives will be posted to our social channels afterwards. So if you joined late, if you had to duck out in the middle, you're able to look at it all on demand whenever you want to watch it or when you're ready to study. Join us again tomorrow at 11 a.m. and 7 p.m. for mental health questions. And thank you so much for joining. I'll see you guys soon.